Welcome to the SMA podcast series, A Day in the Life, a publication of the Southern Medical Association's Physicians in Training Leadership Working Group, composed of medical students and residents, whose mission is to provide a forum to plan and design new educational activities for physicians in training.
Today, we are joined by Doctors Marina and Fabrizio Galimberti, who both recently graduated residency from the University of Miami, who will be discussing their article, U.S. Dermatology Resident Responses about the COVID-19 Pandemic, Results from a Nationwide Survey, which appears in the September 2020 issue of the Southern Medical Journal. During this podcast, they offer insight into how medical training was affected by the pandemic, the uncertainties residents faced, and what improvements can be made to better address and cope with a potential second wave of COVID-19. Thank you both for joining us today.
Thank you so much for having us.
Thank you, it's a pleasure.
You did this article, as we just mentioned, because of the pandemic and what dermatology residents were facing and what they were experiencing. Why was it important to address this at this time?
Yeah, so it was important to address this issue at the particular time that we did the survey, which was in the beginning of April, because that was kind of towards the beginning of the COVID-19 pandemic when things started to shut down and people started going to quarantine. And this survey really brings up the uncertainties that dermatology residents face at such an unprecedented time. This is probably the first time for a long time that outpatients were canceled and closed, and residents who are used to being in physical clinics to seeing patients as an outpatient, they had to shift to either working from home, seeing patients via teledermatology platforms, or just kind of studying on their own, or even being pulled to work with COVID patients. Because of all these changes, we thought it was a good time to get opinions from all our colleagues across the nation and see how different residents in different departments really coped with this issue and all these changes. And then hopefully their opinions and the results of this survey will help shed light on what we could do to better cope with a potential second wave of COVID in the future.
As you did your study, what did you find that was possibly incorrect or misunderstood or not really widely known, especially as it relates to specialty medicine?
Yeah, so maybe some public members who are not in medicine or don't know anyone in medicine may not know dermatology, radiology, and ophthalmology or other specialties like this were often not trained for more than 1 year in general medicine. So for example, we do 1 year of general medicine training, and then we go into our subspecialty or specialty training for the rest of our residency. So in this 1 year of general medicine training that we do right after medical school, it can be done as a transitional year, a preliminary medicine year, or even a general surgery year. And what this means was that not any particular resident will have the same experience or same amount of time that they spend on inpatient wards learning about general medicine. Some people might go through this 1 year only being on the general medicine ward for a month out of their whole year. So really our backgrounds are very different. And I think this is important to know because some of our co-residents have been pulled to take care of COVID patients, and then the public might not know that maybe a lot of them have not had the same training as general medicine residents. So I think that's something important to know. And I think this sheds light on why some residents who responded to the survey did not feel comfortable at the prospect of working for an emergency room on an inpatient ward or even working in an ICU.
Yes, and I completely agree with what Dr. Lee said about that. So, it was a unique time in history when the virus started becoming more prevalent in the United States, and physicians, just like the rest of the population, were scared about the virus. We didn't know pretty much anything about it at that time. We didn't know how to take care of this virus. We didn't know how serious or not serious it could be. But then physicians, especially residents, they were kind of faced with this double issue of, how do you take care of yourself and how do you take care of your patients? And many of us in subspecialties felt that we wanted to take care of patients, yet we didn't feel quite ready at the same time to take care of them. And what I mean by that is that maybe some of us didn't do medicine for over 3 years. So although we were very trained or were getting excellent training in our specific subspecialty, we really were not comfortable or did not quite remember how to, let's say, intubate a patient or how to do it safely, especially. So it was a unique time, and that's really what captured our own personal fears. But by chatting with some of the other residents that were lucky to know at other programs, we found out that this was a common issue. And we wanted to study the dermatology residents, or at least reach out to the dermatology residents, almost like a proof of principle concept. And what I mean by that is the idea that what we learned from the dermatology residents, most likely we can extrapolate for all the other subspecialty residents. And in a sense, perhaps, what we can learn from the small group of people, we can use it to better prepare for the future, not just for subspecialty residents, but also for the entire country, for the entire population.
You touch on the didactic teaching and how that folded into the residency training and what the ACGME, those requirements as well, because I know that residents that we have spoken to were very concerned about meeting a lot of their requirements and how COVID was affecting their training in that regard.
Yeah, sure. So ACGME, or the Accreditation Council for Graduate Medical Education, is kind of the overseer of how residents get trained. And they have a set of minimum standards that the residency programs must meet and that each resident must meet in order to graduate. So for example, for dermatology, and then I assume for other subspecialties as well, the program has to have a firm curriculum which incorporates didactic education through either lectures by the faculty or lectures led by co-residents that go through particular topics, so that everyone can be on the same page regarding common diseases or things that we don't see often in clinics. And in addition to that, there's a set list of procedures, and then we have to meet a minimum number of procedures in order to graduate. So for dermatology residency, for example, we might have to do 50 excisions by ourselves or witness over 100 excisions overall in order to graduate. And there's like different procedures like that. There's cosmetic procedures that we have to either witness or do ourselves. And I think a lot of these didactic teaching and hands-on learning has been impacted by COVID because of the clinic closures and because of residents being pulled to cover other specialties. And because of this, a lot of residents in April were very concerned that ACGME was going to come and say, oh, you guys can't graduate in June because you didn't meet your minimum requirements.
Yeah, I completely agree with Dr. Lee on this, but I do want to applaud ACGME because they were pretty prompt in letting residents know that they were going to decrease the number of required cases to graduate, so there was not going to be any delay in graduation if a residents were not to meet the requirements. However, this does not change the fact that some of the residents feel that this time where the clinics were closed, this time where the entire healthcare system was rightfully directed toward the care of COVID patients and not other conditions, might impact in the long-term learning experience. So there is this feeling of we want to take care of COVID patients. However, in the back of our mind, a lot of residents wonder, how does this impact our education? And interestingly enough, what we notice is that although the majority of the residents agree that clearly COVID had a negative impact on their education, I do want to underscore that the majority of residents, overwhelming majority of residents, did feel that there was a value for online education. And I think that underscores that even on a national base, having any type of educational opportunity is better than having none, even though the over the internet type of education, the remote type of learning might not be the optimal one, particularly for procedures that are more hands-on or procedural type of learning.
As it relates to your survey, which was sent to, I believe, 50 different residency programs, and you did have a response of 140 residents, so I think your participation was very strong. Gleaning from that information, what do you believe listeners should know or be doing in order to improve the quality of care as it related to your study and its findings?
Well, in terms of preparing for a potential second wave, as demonstrated by the survey, many dermatology residents did not feel comfortable working as a medicine resident on the floors, in the ICU, or in the emergency department. And then, as we mentioned previously, there's like multiple factors that goes into these responses, and some of it is due to the uncertainty of the COVID pandemic in general, and the residents being worried for their own safety and for their families. And another part is that they just honestly don't feel prepared to work on these floors because they haven't received the adequate training in order to work as a medicine resident, or they're so far removed from their general medicine year that they really feel overwhelmed by this idea. And I think in order to improve quality care in the future, is that preemptively we should have subspecialty residents, such as dermatology residents, trained so that they at least are able to function as basic interns at a more comfortable level. So that could mean that making sure that all the residents are ACLS trained as opposed to just BLS trained. So for example, in our residency program, after the first medicine year, all of us can just be BLS, which is basic life-saving, which is a more fundamental level of like doing CPR, giving rescue breaths, whereas ACLS is a level that is the advanced life-saving skills, which is, I think, what you require when you work in the hospital. And then this takes like a weekend, and it's something that's easy to do in preparation for potential like outbreak or increase in caseload in the future.
Yes, I think that's very important. And I'm going to go back to something that a famous historical figure said, one of the founding fathers. So what we wanted to emphasize is that basically an ounce of prevention is worth a pound of cure. We want to make sure that whether or not there is a second wave, which seems to be the most likely case scenario, but whether or not there is one, we can, since we already have a history with this virus and we can learn from what happened before, we can prepare for the future. And we do think that it will be important for one of the most important steps for the preparation for the possible second wave will be having all physicians trained for ACLS or trained to function in a intensive care unit type of scenario.
And of course, just making the residents feel comfortable about working on the COVID floors is making sure that they have their proper PPE, their protective gear, making sure they have the support. So for example, a lot of residents were worried that what if they test positive for COVID, or what if they don't get tested and they have symptoms? So there's a lot of uncertainty about that. So if we could reassure them, providing them with the appropriate PPE, letting them get tested and get retested when they have any sign of symptoms, and then even providing them with things like childcare or discounts on housing options, so that if they don't want to go home and potentially get their family members sick, they have somewhere to stay without having to worry too much about finances. So I think improving the support behind our residents, improving their education, are areas that we can work on to improve quality of care in the future. And then another term, going from another standpoint, to improve quality of care for the subspecialty of dermatology. So how do we make sure that our dermatology residents graduate and then they become good dermatologists in the future? Because in a sense, they are losing time in their own specialty training. This will be hard to do because dermatology is one of the specialties where we have a large patient volume and we learn a lot in our first year of training. So I would say before COVID, dermatology residents see over 30 to 40 patients a day in order to develop good pattern recognition and learn how different conditions look like in patients with different skin colors and how to treat them. And with this decreased patient volume now, and I anticipate it'll continue being reduced in the future due to the need for social distancing, I think it's very important for different programs to develop ancillary learning tools, such as visual lectures, group projects, maybe different in-cervix exam or cadaver workshops, and all these ancillary programs to make sure that the residents still get their subspecialty training and that they remain on track in that sense.
Could you talk a little bit about the lack of ethnic variability in study materials, such as the literature, the journals, as well as books, textbooks, other learning materials?
Yeah, so this is a hot topic right now in dermatology. Multiple studies have come out looking at the ethnic representation of different skin colors in our medical textbooks. Because dermatology is such a visual field, it's very important for us to see what different conditions, such as psoriasis, atopic dermatitis, what they look like in a lighter colored person versus someone with darker skin color. If we don't see enough of these patients or see enough pictures like this, sometimes we may miss a common skin condition or miss something potentially very harmful, like mycosis fungoides, which is a type of cutaneous skin cancer. So a lot of the ways we learn about what different skin conditions look like is through seeing patients. So with that aspect kind of reduced due to decreased patient volume, we turn to our textbooks. And when we look at textbooks and different journal articles, we realize that most pictures are taken from skin colors 1 to 2, 1 to 3, which meaning on the lighter side of things. Again, in order to learn how to treat everyone, we have to increase diversity in our educational materials. And that's something that I know different groups are trying to tackle by improving representation of different skin colors in our different journal articles and possibly revising our current textbooks to make them more diverse.
Yeah, correct. I agree with Dr. Lee. I think it's of crucial importance to tackle this issue. Now, we're lucky where we are here in the South, in Miami, because we have a very heterogeneous city. We have a chance to learn from every patient that we see of all different type of origins and background. But it's important to realize that, of course, the United States is a large country with different distribution of populations in different areas. Nonetheless, no matter where residents train, they end up most likely moving to different areas. So it's important to be trained in all type of skin conditions, in all type of patients, because that really can make a huge difference in terms of accurate and rapid diagnosis of skin problems that can have long sequelae. So the earlier they're diagnosed, the better can be treated. This is an important topic, and I'm glad that there is a lot of attention nationwide on this. And I think we're about to see a big change in how training for different type of skin colors happens, at least in dermatology.
We've talked about how the pandemic has affected training, the lack of in-person training, and how you're having to shift to more textbook or telemedicine or online learning. Are there other specific barriers to be aware of because of the pandemic and when residents were not allowed to see as many in-person patients? I mean, are there barriers that have arisen as a result of COVID-19?
Yes, as you said, because we're not seeing as many patients in person, there is a worry that maybe dermatologists or residents wouldn't be as well trained in procedural dermatology. Procedural dermatology can range from a wide variety of things, such as excision of skin cancers, performance of Mohs surgery, and different cosmetic procedures like lasers, injecting neurotoxins and fillers, doing peels, and things like that. These are things that we learn by seeing and by doing. Sure, there are a lot of good resources now. Our different societies like ASDS, WDS, they post a lot of different virtual lectures that we can watch that help us improve our understanding of procedural dermatology. But without actually doing, I think this is an aspect that might suffer in dermatology training in the future. So I think programs have to be more aware of that and, again, maybe provide some kind of ancillary curriculum to kind of fill in the gap here. So for example, I know University of Miami, where I'm at right now, they're trying to do maybe a virtual or small group excision workshops where residents can buy pig skin or buy synthetic skin and practice excisions and suturing on. And we're trying to do different cadaver workshops where can explore the facial anatomy. And so hopefully that the younger residents that just came into residency now can still get their basic level of procedural dermatology so that in the next year or two, they can continue to improve.
A lot of graduating residents were worried about job prospects during the pandemic. Do you think there is still this concern?
Oh, for sure. I think before, when the survey was sent out, it was in April. So at that point, I think more of the graduating residents were concerned, and overall, seems like not too many people were concerned. I would say majority of the residents were either neutral or were not concerned about the job prospect. And then at that point, the graduating residents were slightly more concerned compared to the non-graduating residents. But now it seems that as the pandemic is dragging on, just from personal experience and from speaking to other co-residents in the country, that there's more of a growing concern now that it's going to affect the job market. I spoke to some co-residents that graduated, and some of them did have a full-time job lined up, but maybe now it got delayed or pushed back. Or they were in the process of negotiating salary when the pandemic hit, and now they are not able to negotiate as a high base salary. Or some of them did have full-time job offers, but now don't anymore. So they have to work for different locations, different companies. And then those who are trying to pursue locum tenens, which is you kind of go around working for offices that need a dermatologist for a short period of time. Those jobs also seem to be dwindling as well. And then because this is affecting the graduating class of 2020 now, so with the way things are going now, the job market could be further impacted for the next couple of months and can affect the upcoming graduates, the 2021 graduates as well, because now they have to compete with the 2020 graduates who might not have found their long-term jobs yet.
Yes, I agree with Dr. Lee. I think the pandemic has really impacted the entire nation, not only on their health and their well-being in terms of the physical well-being, but also in terms of their financial well-being. The road to recovery is long. The path to the recovery, it's unclear at this point, of course, as just like there are so many unknowns related to this pandemic at this point. Dermatology just being part of the one of the many subspecialties depends on outpatient procedures, which were canceled during the pandemic, probably suffer a lot from this. Now, this will have long-term consequences, of course, on the field of dermatology itself, how it will evolve with time. The advent of teledermatology, which was a very, very minor part of dermatology as early as January 2020, and now it's a significant part of dermatology, has really changed a little bit our discipline. Now, as dermatologists, we want to take care of patients, we want to be as involved as we can in the healthcare system. We're looking for of course, just like anybody else, for the recovery of the country on a physical, emotional, and financial level. So we are just like the rest of the population. We understand there's going to be challenges ahead. We do think that we're still getting phenomenal trainings that we're going to be ready to help patients. But just like anybody, we have a little bit concerns about what's going to be the next step for us as individuals in terms of job markets and so forth.
I'm interested to see if any of the subspecialty fellowships are going to be more competitive because of the poor job market. Graduating residents who, because of the lack of procedures they got in the last bit of residency, may feel that they can't find their dream job, so why not perfect their skills by doing a fellowship? So that might drive up the number of people applying for these fellowships, like ASDS Procedural Fellowship or Mohs Surgery or Dermatopathology Fellowship. So in that sense, fellowships can become more competitive. And I guess we'll see this after the upcoming match.
Going back to a more study survey specific question, your results showed that dermatology residents were affected by COVID-19 with regard to their well-being, training, and education. Did your survey and the responses yield any information that you didn't necessarily expect, sort of some surprises, good or bad, that you didn't, like I said, were a surprise?
I guess I was surprised that I think majority of respondents said that I think 90% reported that their education was negatively impacted. I was surprised that 10% didn't feel that way. So I don't know why that's the case. I presumably maybe their normal clinical duties were very time intensive. So with the pandemic, maybe now they finally have time to sit down and read textbooks and journals. Yeah, we have a very heavy textbook that we have to read called Bologna. And it's hard to get through when you're in clinic all day. So maybe this time the 10% that responded, they didn't feel that their education was negatively impacted. Maybe they're at home reading or writing, something like that.
Yes, I agree. I think it's possible that some of the respondents were able to allocate their time in a different manner that was more beneficial for their education. Although nonetheless, we cannot underestimate the fact that the majority, as you would expected, did find that COVID negatively impacted their education. And I think that's most likely something that, once again, we can use as kind of a proof of principle concept and most likely be able to expand to all other residents independent of their subspecialty.
This has been such an informative conversation, and I thank you very much for taking some time to talk with us today. Before we conclude, are there any final takeaways or pearls of wisdom that either of you would like to share with our listeners?
I know about pearls of wisdom, but I think this is a very unique time, and there's just a lot changing everywhere in the hospitals, in our personal lives. It's been challenging for almost 90% of people, for almost everyone. And I'm really proud of how the dermatology residents that responded to the survey and those who maybe didn't get a chance to respond, how they handled things. Like majority of residents were able to switch to a virtual based didactics, and they continue their education. And then they try their best to help patients, and props to the people that went onto the COVID wards and helped relieve the medicine residents. I think we really pulled together to help each other through this tough pandemic, and I really hope things will get better in the future.
I completely agree with Dr. Lee. I think a lot of things happen, a lot of changes, sometimes sudden, sometimes more expected, sometimes really unexpected happen. And really what this part in the survey emphasizes the fact that physicians in general, whether they're residents or attendings, they really try their best, and they usually strive for perfection, at least to do the best job that they can. I think that for me, the take-home point here is that physicians want to be trained and they want to be able to help as many people as well as they can. So being prepared, whether there will be with different types of educations to supplement the time that we don't have in clinic now, whether that will be for training for inpatient wards via ACLS training, it's really what we want to be ready to help as many patients as we can in the best possible way.
Thank you again very much for today, and we appreciate your time.
Oh, thank you.
Thank you.
Thank you for listening, and stay tuned for more Physicians in Training podcasts. To view all of SMA's podcasts, visit sma.org/podcasts.